Thank you. Thank you for the introduction. My presentation will be some kind of follow-up of the previous presentation that was introducing biomarkers. I'm talking specifically about genetics. Don't worry, I will not be too technical. I'm a clinician, as many of you. So the main aim is to try to make an overview how genetics can be useful to the clinical practice now and possibly in the future. Let's start from the reality. This is a reality of a small sample of our patients. That is more or less what is common experience when we treat a patient with antidepressants, but it is the same for antipsychotics, it's the same also for mood stabilizers in a long time. Not all of them go the same way. Some of them respond immediately, some of them don't respond at all, some of them seem to worsen and then respond, and so on. So the challenge for every clinician is to try to understand, to predict, to have an idea how the patient will go, and so prediction. And then it would be useful to have some kind of guidance, because guidelines are useful for us. We have seen in the previous presentation this afternoon a lot of new treatments, a lot of old treatments, and it's very difficult to choose the right one. And this is exactly what genetics is partially doing now and promising for tomorrow. Predict the outcome of a patient and guide us to select possibly the best treatment for every patient based on genetic profile. Just one slide about what we know about clinical predictors, because they are important, of course, and this is just something that has not been published yet, actually not yet submitted, will be submitted soon. Is a very large neural network analysis that we did to find the clinical predictors of treatment-resistant depression. There are a lot. This is common clinical practice. We know, this is something that we know. It is just formalized in terms of mathematical ranking, but it's something that we know from experience. Obviously, if we have a long duration of the episode, think about chronic depression, patients that are depressed since more than 2 years, it's very difficult to treat them. And also the same, long duration of disease, late age, and all the usual suspects, I would say. So a lot of clinical predictors are useful in clinical practice. Sure, if we have a patient with a long episode, long duration of disease, and so on, we can say, well, this is a patient to be at risk to be resistant depression. And could be the same for schizophrenia, for bipolar depression and maintenance and so on. Okay, but they don't tell us what we should do in terms of treatment. And this is what genetics is doing a little bit more, is adding to the clinical information. It's not substituting, it's just the complementary information that we have compared to the clinical analysis of patients. And these are the kind of newspapers articles that you see almost every day in the press. Since many years, there are a lot of claims that commercial products are very useful to predict everything, to choose the drug, to predict resistance, and so on. It is not so simple. I will try to give you some information in this presentation, and also in the next one you will have some. Let's start from what is completely known at present and what is certain. That is the clinical guidelines that we have. We have a couple of groups in the world that are most important for guidelines. The Clinical Pharmacogenetic Implementation Consortium and the Dutch ones. They are useful because they give some kind of guidelines. What they say, they apply to a considerable number of antidepressants and antipsychotics, and they say something very simple. If you have a specific pharmacokinetic genetic profile, you should be careful. All of you know that we have different liver enzymes, have been mentioned also before this afternoon. We can be 10% about poor metabolizer, that means that we metabolize very slowly the treatment that we are taking, or we can be rapid or ultra rapid metabolizer, and we metabolize a lot the treatment. This is a very simple genetic that is already available in the clinical practice. And it's useful for us, because if a patient is a poor metabolizer, there is a risk that if you give a normal dose of antidepressant or antipsychotic, you have too much plasma liver and therefore side effects and so on, the opposite for the ultra-rapid metabolizers. This is something that is important because, as we demonstrated, not only for the antipsychotic, but this is quite a recent mega-analysis that we have performed on our samples, but there are also converging evidence from the German group that works on therapeutic drug monitoring. Indeed, it's important to have the right plasma level. This is a combination of various antidepressants. We made a study on escitalopram, duloxetine, venlafaxine, and all of them they have a curvilinear dose-response relationship. So this is the plasma level, this is the antidepressant response. If you have a too much low plasma level of any drug, of course, it doesn't work. If antidepressant is below a certain threshold, it doesn't block the serotonin transporter, it doesn't go to the serotonin 2A, to C, and so on. So it doesn't work. And this is not surprising that a lot of patients with small, low plasma level don't improve in the Hamilton. Of course, some do for some kind of probably metabolic differences, blood-brain barrier differences, but overall there is an effect in this direction. And therefore, the perfect range of plasma level is the intermediate range. If it is too much in the blood, then again it doesn't work well because you have more side effects and you can have other kind of pharmacodynamic issues. Therefore, the genetic that we have now is very useful to keep the patient in the right range of plasma level. Of course, we could do the plasma level every time that we prescribe a drug, but it would be very long. So if we have, and in many hospitals, in many universities in the world, they are already doing it, you make a profile from a genetic point of view. If you are a poor metabolizer for the CYP2D6, be careful about the drugs that are metabolized by CYP2D6, paroxetine and so on. The same for the other CYP enzymes. So every patient has some kind of profile. And the clinician can see, if you have an electronic health record, it's very simple, you prescribe paroxetine, pops up, be careful, this patient is a poor metabolizer, stay low with the dose, or the opposite is a ultra rapid metabolizer, go up with the dose. Very simple. PT that is not done everywhere. Hopefully it will be done everywhere, because this is already in the guideline. We know that all of us still are not doing it because it's not easy. We don't have the lab close to us, we don't have the electronic health record, but be aware that soon I think it will be quite spread. And this is the easy part. And I will go now briefly on the most difficult part that will be also discussed in the next presentation. Genetic can be useful for this part, that is the plasma level of the drug, guided by the metabolizing enzymes of the liver. But genetic can be useful also for what happens other than in the liver, like in the brain, the blood-brain barrier, and so on. Here comes the concept of polygenic scores. Because for more than 2 decades, we were thinking that single genes can modify antidepressant response or tolerability. It's not the case. It's not the case, because the interactions in the brain and in the genetic background are too many. So no single gene can do an effect that is clinically relevant. This for sure. At least the pharmacodynamic one. I'm talking not about the liver one. Liver, sure, but the pharmacodynamic, the brain. So the genes for the serotonin receptors, genes for the dopamine receptors, and so on. So polygenic scores is a combination of scores that gives some kind of directions, some kind of combinations in pathways, dopamine pathways, serotonin pathways, and so on. This kind of studies has been performed a lot in the recent years. This is a couple of them. The one below is at present the largest that has been performed so far. About antidepressant response and the genetic profile combining all the genes that we have in the genome. What results say? Well, not so much from a clinical point of view so far. We cannot use the results from these kind of studies to guide the treatment now. But maybe in the future we will be able to do it, and we will see in the next slides a little bit which are the possibilities. But one information is there, the information about the irritability. It means that the antidepressant response is demonstrated by the studies and also others that is indeed controlled by genes in a large part of the variance, talking about 20, 30, even 40% of the variance, depending from the estimates. So it means that genetics is important. Still, we have to find exactly which part of the genetic is important. There are many kinds of genetic analysis. We can do some sampling of the genome, or we can sequence whole the genome. That is more expensive, more difficult to analyze, and so on. We did so far the largest study about exome sequencing in about 1,000 patients. Results gave us some interesting indications that, in particular, the pathway linked to neuroplasticity and stress or inflammation are involved with the antidepressant treatment outcome. And this is in line also with the biomarkers that have been listed before, and all you know about depression, that is plasticity reaction. When you prescribe an antidepressant, something plastic happens in the brain. It means that the connection between the limbic areas, the frontal areas improve, and so on. And inflammation is also something important. So this is some kind of confirmation that we are going in the right direction. And using a combination of the clinical predictors that I've shown you in the first slide and the genetic predictors, indeed this is a standard ROC curve, indeed we can start to predict in a clinically reasonable way what's happening to the patients. So we are close, even if still not for a direct clinical translation, but we are getting closer. In this other paper, we made it more clear for people that is not in the field of genetics. What are we talking about? We are talking about something very simple, that is number. So we make this example, a subject 1, 2, 3, so on, pathway 1, 2, 3, so on. What is pathway 1 could be the serotonin pathway, pathway 2 could be the dopamine pathway, path 3 could be the neuroplasticity pathway. And every person, every subject has some kind of score. This is standardized, therefore it's a standard deviation. It means that each of us is different. We could have a very, let's say, reactive and plastic serotonin system, but maybe we can have a disadvantageous dopamine system. And then we have a combination of all these scores. That is again a number. And this number can be combined with the number of clinical predictors. This is what will be the model at the end. And indeed, we are starting to go in that direction. Talking about prediction, in this other paper, it was possible to have some signal of prediction in terms of polygenic scores of depression for the risk of depression itself, but still is not so strong. We are talking about odds rates of 1 point something that is not clinically relevant so far. In this other paper, things are getting a little bit more interesting. It will be detailed in the next presentation, but just for now, look at this part that is the polygenic score for bipolar schizophrenia, and these are indeed some kind of risk factors for antidepressant outcome. In this case, negative outcome. And I told at the beginning of the presentation that genetic should be useful for predicting and guiding. Well, there is starting to appear some evidence of the possibility that genetic can guide the choice of our drug that we are prescribing. In this paper, but it's not the only one, there are also other literature. This is probably one of the first that we did a few years ago. We just observed exactly this. Talking about polygenic score of schizophrenia, that means the genetic predisposition of schizophrenia. That doesn't mean that the patient is schizophrenic. The patient can be clinically measured depressive patient, but with a polygenic genetic prediction risk for schizophrenia, even if the patient, again, is not schizophrenic, is depressed, but with a genetic similar to the patients with schizophrenia. Well, if it is the case, and this is the polygenic score for schizophrenia, the more you have the genetic predisposition of schizophrenia, the higher is the risk of being a treatment-resistant patient of depression. So this is starting to be something that is useful also in clinical practice, because it is a measure that you can do only once in your life, and once you do it, it is forever. So you can use the electronic health record, and you can combine with other things that we will see later. But this is also something that is even more useful in clinical practice. That if a patient has a high polygenic score for schizophrenia, then also the treatment outcome is different, not only in terms of being more resistant, but more sensitive to specific drugs. Which drugs? In this case, antipsychotics. So it is common, we always, when we have a patient with treatment-resistant depression, we try the combination of SSRI and some atypical antipsychotic, olanzapine, quetiapine, aripiprazole, whatever. Well, if the patient is with high polygenic score of schizophrenia, that means a genetic background that is similar to schizophrenic patients, it responds well, better to the typical antipsychotics compared to the patients with low polygenic score. And this is the first and very nice, in my opinion, from a clinical perspective, example of a clinical guidance. So it means that we could have a combination of polygenic scores of different traits that give us a specific prediction and guidance. And things are getting more and more complicated. In this extremely recent paper that I think was published a couple of months ago, they extended, it's small, maybe you cannot read it, but they extended the polygenic score to a lot of traits, a huge number of traits, like tension, like insomnia, like many others. And many of them, indeed, are increasing the risk for treatment-resistant depression. And some are protective, education, cognitive performance, genetic, not clinical, genetic predisposition to higher education, genetic predisposition to cognitive performance, and are protective. So you start to understand that we need to combine all this information. Every patient has hundreds of these numbers. Every patient can have a high polygenic risk score for schizophrenia, a low polygenic score for bipolar, and so and so and so on. And so every patient can be placed in any point of the distribution. Someone can have a high polygenic score for schizophrenia, intermediate for bipolar, and low for depression. Then would be a patient that is a candidate for atypical antipsychotics. Or we can have a different combination, and this is only three polygenic scores. Consider that at present there are more than 4,000 of polygenic scores, all of them. And indeed, the evidence is mounting. We just published last month this review, and when I was making this figure, I was really surprised because this figure is a very simple one. Every circle is a study there, a study about the effect of polygenic scores of schizophrenia in what? In schizophrenia outcome, depression outcome, and bipolar outcome. And really, I was surprised to see that I was feeling all of them because red, it means positive association. So it means that in the large majority of the studies out there, polygenic scores of schizophrenia have a transdiagnostic negative effect on schizophrenia treatment, depression treatment, bipolar treatment. And the dotted one are trends. So I think that we start having quite substantial converging evidence that schizophrenic polygenic scores, to talk about one, and then we have many hundreds of others, but one is clearly having a transdiagnostic detrimental effect on outcomes. And this is something that can be relevant for treatment. Of course, it's not only that. This is another very recent review that was published, I think, last week, where we try to put more together, a wider picture. We are talking about genetic, but you heard before Professor Gonda talking about all the other biomarkers. We should consider them, of course, with the genetic together, all the proteomic biomarkers, all the imaging biomarkers, and so on. And to combine them. Combine how? We will see in a few slides. In the meanwhile, you can find some people that is offering now pharmacogenetic prediction. Be careful, because at present the pharmacogenetic prediction that is sold by companies is still based on a limited number of genes. The CYP, the liver enzymes, good. This is scientifically correct. But the pharmacodynamic part of this test is still not completely demonstrated. So they could be useful, but as the papers say, the science might be getting left behind a little bit until now. So this is just a warning, not to use them, but to consider them carefully for what they can do. So what I suggest at the end? I suggest that genetic, in this other review, genetic is for sure something that is useful because we can use the clinical profile as I showed in the first slide, sure very useful. We can use now the CYP, the prediction of poor metabolizer, rapid metabolizer, to know the plasma level to avoid the risk of having too high or too low plasma level. And in gray, because it's not yet available, but will be soon, a combination of polygenic scores. Combination of polygenic scores that can give us the complete picture. What we have at the end? For every patient, we have the genetic information, clinical information, that must be combined together. How? The previous presentation already mentioned. In this slide, I show you what is the future. You know, you're familiar with the large language models, ChatGPT, Gemini, Claude, and so on. At present, and I say at present, and in JAMA, this is the JAMA journal, JAMA Open is a prestigious journal. At present, this model are in many cases better than us. Better than us. Now, and they are improving very quickly. So this is just demonstrating that the diagnosis of very difficult cases is performed better from the model than from a specialist. Okay, we can discuss this, this is not the place, but I want to say that this model will be the future. Because of course, this model can integrate very easily a combination of polygenic scores, even thousands of them, that we cannot do with our mind, we cannot do with trivial statistical tools like regressions or neural networks. We need something more powerful. So, conclusion. Prediction of antidepressant response, but could be also antipsychotic or mood stabilizer, using clinical factors is important, is useful, but is not sufficient. Multimodal predictors is already available. The CYP is already available. It will be more and more common in the future. In any case, never it is meant to substitute our experience. Even if when we will have the large language models that can do diagnosis and treatment better than us, I hope that we can be useful as well also in that time. Thank you for your attention.